I'm student Dr. Taylor Moulton, a second-year medical student at the Idaho College of Osteopathic Medicine.
And I'm student Dr. Dylan Travis, also a second-year medical student at ICOM, and we're working alongside Dr. Joseph Williams at Idaho Urologic Institute. In this video, we're going to be talking about priapism. Priapism is defined as a persistent and prolonged penile erection lasting longer than 4 hours that continues beyond or is unrelated to sexual stimulation. It's important to note that priapism can be a medical emergency, and if any erection lasts longer than 4 hours, emergency medical assistance should be sought. In order to better understand priapism, let's take a look at the anatomy of the penis, specifically during an erection. To cause the penis to become erect, arteries bringing blood into the penis expand, allowing for more blood flow. Blood fills two spaces on either side of the penis called the corpus cavernosum. Pelvic muscles and membranes tighten to stop blood from leaving the penis, increasing the pressure inside the penis and resulting in an erection. Under normal circumstances, this process takes place in response to sexual stimulation, and orgasm or removal of the sexual stimulation results in relaxation of the muscles preventing blood from leaving the penis. This results in detumescence, or end of the erection. In priapism, however, erections persist beyond orgasm or removal of sexual stimulation, or they can occur outside of sexual stimulation. Blood becomes trapped in the corpus cavernosum, which can lead to pain, clotting, and even cell death.
There are two types of priapism, ischemic and non-ischemic. Ischemic priapism is the most common form of priapism and is a medical emergency. Ischemia is defined as a lack of blood flow to the tissues of the body, preventing oxygen and nutrients from being delivered. After the blood has delivered the oxygen and nutrients, it gathers waste and returns to other organs. Ischemia is a lack of flow, usually due to obstruction, preventing delivery of oxygen and nutrients and the clearance of waste. The lack of blood flow can result in death of the tissues in the penis. This is why ischemic priapism is a medical emergency, and without intervention, the penis can become scarred and damaged beyond repair, leading to lifelong issues. The second type is called non-ischemic priapism, also called high-flow priapism. In this condition, blood is able to flow into and out of the penis during the erection, which allows oxygen and nutrients to reach the tissues in the corpus cavernosum. Ischemia and cell death do not occur. This type of priapism is usually related to either an abnormal connection of blood vessels in the corpus cavernosum or due to trauma to the penis. Non-ischemic priapism is not a medical emergency. It is important to note, however, that only a physician can determine if a prolonged erection is ischemic or non-ischemic, and medical help should be sought for any erection lasting longer than 4 hours. In this video, we will be focusing on the signs and symptoms of ischemic priapism, as this condition is a medical emergency.
Priapism can be caused by a variety of things. Worldwide, the most common is sickle cell disease, where genetic mutations cause the body to produce abnormally shaped red blood cells. These sickle-shaped red blood cells become trapped in the penis, resulting in an unwanted erection. This is also the most common cause of priapism in children. In adults, especially in the United States, the most common cause of priapism is the use of injectable erectile dysfunction medication, most commonly phosphodiesterase type 5 inhibitors. When these medications are injected into the corpus cavernosum, they cause relaxation of the smooth muscles in the blood vessels in the penis, aiding in an erection. When these blood vessels fail to take blood out of the penis by tightening back up, the erection fails to subside. The primary symptom of priapism is a prolonged, painful, erect penis. It is important to share with the physician how long the erection has lasted, if you have any history of prior episodes of priapism, if you have a history of blood diseases such as sickle cell anemia, if you use any medications, especially injectable or non-injectable erectile dysfunction medications, if you have experienced any trauma to your groin region, or if you use any recreational drugs. This information can be vital in helping the physician quickly and accurately determine the cause of your prolonged erection. To determine the need for emergent treatment, the physician will likely perform a cavernosal blood gas analysis. This will take a sample of the blood in the penis to evaluate for signs of ischemia or cell death. In ischemic priapism, the blood sample will appear black and show signs of ischemia. In non-ischemic priapism, the blood sample will be red and not contain the markers of cell death and ischemia. If ischemic priapism is suspected, emergency treatment will be initiated.
Treatment depends on the cause of presentation and the duration of the condition. The goal of treatment is clear: stop the erection and prevent further damage. The process depends on the type of priapism and the severity of the condition. The severity is judged based on the timeline of the erection and how well the patient is responding to treatment. Ischemic priapism is an emergency and must be treated as soon as possible. Conservative therapies such as observation, oral medications, cold compresses, or exercise are unlikely to be successful and should not delay definitive therapies. It is important to understand that acute ischemic priapism can lead to erectile dysfunction. For patients with an acute ischemic priapism event for more than 36 hours, there is a low likelihood of erectile function recovery. Before any invasive intervention is done, a penis block is done with lidocaine to prevent further patient discomfort. Emergent treatment for ischemic priapism involves injecting a medication called phenylephrine. It contracts some of the muscles of the penis, promoting the drainage of blood and relaxation of the erection. It also lowers the risk of subsequent erectile dysfunction. Generally, phenylephrine carries a minimal risk of cardiovascular side effects. Its high effectiveness and low risk make it the drug of choice for treating priapism. Though it carries low risk, the patient's blood pressure and heart rate should be monitored throughout the treatment. Aspiration or drainage of the penis is also necessary to relieve the erection. This involves using a needle to drain the trapped blood from the inner structures of the penis. Fluid can then be injected to the other side of the penis in an attempt to promote drainage of the bad blood through the other side. This is a process called irrigation. Studies investigating the use of phenylephrine with aspiration and irrigation to treat priapism show up to an 86% success rate. For those instances where the use of phenylephrine, aspiration, and irrigation are all unsuccessful, surgical therapy is then required. Shunting is a process where alternate pathways are created for blood to flow. It is done at the tip of the penis and is called a distal corporal glandular shunt. This allows for blood from the corpora to drain forwards in the glands of the penis. There is inadequate evidence that a proximal shunt after a distal shunt provides any benefit. The blood is then monitored after the shunting to check for oxygen returning to the affected tissues. For severe cases that show little improvement with treatment or are unlikely to make a functional recovery, implantation of a prosthesis is suggested. Implantation is also recommended for untreated ischemic priapism lasting longer than 36 hours. The prosthesis helps reduce severe scarring and shape deformation like curving and shortening. Non-ischemic priapism is not an emergency and is best observed first before moving on to treatment. The physician should do an ultrasound to find the cause of the prolonged erection. If the erection is persisting, even after a period of observation and the patient wishes to be treated, embolization is the first therapy. This carries a risk of erectile dysfunction recurrence and a failure to correct the issue. For prevention, lifestyle management can play an important role in preventing priapism. Knowing the risks associated with medications and certain medical conditions like sickle cell anemia can be helpful in preservation.
In summary, you should seek medical assistance if you are having an erection for longer than 4 hours. A physician will be able to determine if the episode of priapism is ischemic or non-ischemic. Depending on which type of priapism is suspected, treatment will be initiated. Ischemic priapism is an emergent condition and requires immediate medical attention. Aspiration, irrigation, and the use of phenylephrine are the first-line treatments, and surgical shunting is an option if these are not successful. Non-ischemic priapism is not a surgical emergency. The longer you wait, the likelihood of successful outcomes decreases. Treatment may be as simple as an injection, but may be as severe as a prosthetic implant.